Hello everyone, my name is Megan Cushman. Welcome to my presentation on cervical cancer in women. The cervix is located between the uterus and the vagina in a woman. Cervical cancer is a slow-growing form of cancer that can be detected in a woman's yearly pap smear exam. Women may or may not present symptoms of the cancer. If symptoms are present, they may include abnormal bleeding, which may be present after sexual intercourse, between periods, or after an exam. Women may also experience abnormal discharge from the vagina and pain after sexual intercourse. We will now take a look at some of the various risk and treatment options. Some of the risks includes the human papillomavirus, also known as HPV, smoking, immunosuppression, a chlamydia infection, a diet low in fruits and vegetables, being overweight, long use of oral contraceptives, intrauterine device use, multiple full-term pregnancies, poverty, being younger than 17 at the first full-term pregnancy, diethylstilbestrol, and family history. Some of the treatment options include surgery, radiation therapy, chemotherapy, and targeted therapy. Treatment is based on stage and aggressiveness. Who is affected by cervical cancer? All women of different ages and races may be affected by cervical cancer. According to the American Cancer Society, in 2015 there will be 12,900 new cases of invasive cervical cancer, and 4,100 women will die of the disease. Hispanic women have the highest rates of cervical cancer, followed by African Americans, Asians, Pacific Islanders, and whites. Women between the ages of 20 and 50 years old are more likely to be diagnosed with cervical cancer, while only 15% of cases are in women over 65 years old.
The first determinant that I looked at was the human papillomavirus. The literature review discusses the different methods of testing in women as well as which testing is best to catch cervical precancer. According to the article, the human papillomavirus is the primary cause for a majority of cervical cancer in women. This is the reason that pap testing in women reduces the risk of cervical cancer by 80%. HPV testing became available in the 1990s and is recommended every 5 years compared to pap-only testing every 3 years in women between the ages of 30 and 65 years old. The HPV vaccine that has recently become available in the last few years reduces the risk of cervical precancer by 75% when women are vaccinated under the age of 14. The article confirms that HPV is a determinant in cervical cancer and that most cervical cancer occurs in women who are not screened.
The determinant that I looked at was being overweight. This article discusses how obesity is correlated to cervical cancer in women. Researchers from Johns Hopkins University looked at different studies of obese women and their rates of pap testing. They came up with 6 physician-to-patient scenarios that may interfere with obese women being screened for cervical cancer. First was the negative body image that obese women have and that may cause them to avoid routine exams. They also found that obesity may be a factor in lack of good health behaviors, which would include screenings. Obese women may not feel they need screening, or they may have comorbid issues that interfere with their ability to be screened. There may be issues with the anatomy of obese women and the lack of equipment to properly test them. Lastly, there may be biases against obese women from physicians who may not recommend further testing and screenings. Obesity is most definitely a determinant of cervical cancer. Determinant number 3 looks at family history. Family history is a known determinant when it comes to many diseases, including cervical and breast cancers. According to the article, 10 to 15% of cervical cancer is hereditary. The researchers looked at 1,112 medical records to determine the accuracy of family history when patients are admitted. Of the 1,112 records, 41% of cases had documented family history of breast and/or cervical cancers. The article further discusses the poor documentation of family history and debates whether second-degree relatives' information should be accounted for instead of just first-degree relatives. Their reasoning was that 50% of mutations come from the paternal side of the family in which the father is not affected. This information is important when looking at one's family history. Determinant number 4 looks at smoking. This article was based off of a study done in Romania at the University of Cebu. The journal discusses the correlation between smoking and cervical cancer. The researchers studied 200 clients from a certain gynecological office in Cebu from 1998 to 2012 that were diagnosed and treated for cervical cancer. The study showed that of the 200 women, 141 of them were smokers and 59 were not. Their ages range from 18 years old to over 70, with the majority of cases in women 46 to 50 years old. Cervical mucus was taken from the women, showed evidence of carcinogens. The study concluded that smoking was in fact a determinant for cervical cancer. The last determinant that I looked at was diet. Researchers looked at evidence supporting that intake of certain nutrients and food groups help reduce the occurrence of cervical cancer. The nutrients included fiber, vitamin C, vitamin E, vitamin A-carotene and B-carotene, folate, lutein, and lycopene. Many of these nutrients can be obtained through a diet of fruits and vegetables. Intakes of these foods are highly recommended by the American Cancer Society. This is a look at the web of causation for cervical cancer. As you can see, there are many different determinants for cervical cancer. Some of the ones that I linked together were poverty, younger than 17 at first full-term pregnancy, and multiple full-term pregnancies. Another group is intrauterine device use and long use of oral contraception. The third group that I paired together was a diet low in fruits and vegetables and being overweight. I was very surprised to find that there were so many different determinants when it came to cervical cancer. From a social work perspective, I chose to look at an article that discussed evidence-based practice. In the article, the authors looked at an evidence-based practice tool to help improve screening and diagnostic follow-up through a program for breast and cancer screening. The screening adherence follow-up, also known as SAFE, protocol included 3 components of evidence-based practice. Number 1 was evidence for known risk and barriers for the target population. Number 2 was standardized assessment elements. And number 3 was evidence for the accuracy, efficiency, and validity of the protocol in use. In the study, more than 600 low-income women from different cultural backgrounds were screened for breast and ovarian cancers over a 3-year period. The patients resided in either Los Angeles or New York City. SAFE was developed as a secondary prevention intervention to help low-income women achieve success in obtaining diagnostic support and treatment if needed after receiving abnormal breast and cervical cancer screenings. Treatment plans were modified for each individual based on their specific needs and barriers. When looking at a community-based response, I chose to focus on the Georgia Breast and Cervical Cancer Program, also known as the GBCCP. The GBCCP is funded by the CDC's National Breast and Cervical Cancer Detection Program. The program provides breast and cervical cancer screening and diagnostic services to women who meet the eligibility requirements. Services include breast and cervical cancer treatment and a full range of services through Medicaid, which are not limited to cancer treatment. Eligibility requirements include that the women must be Georgia residents between the ages of 21 and 64 years old. The women between the ages of 21 and 64 are eligible for cervical cancer screenings, and women between the ages of 40 and 60 are eligible for breast cancer screening as well. The women must be uninsured and must have a low annual income. When we look to see if they are making a difference, we can see that the National Breast Cancer and Cervical Cancer Early Detection Program, in their first 20 years, served more than 4.3 million underserved women and gave them services. Of the 4.3 million women who were served, 56,662 had breast cancer, 3,206 had cervical cancer, and 152,470 precancerous cervical lesions were detected. Without access to these services, these women may have never received the care they needed in a timely manner. According to the CDC, the NBCC-EDP program is the only cancer screening program that serves all 50 states, the District of Columbia, all 5 U.S. territories, and 11 tribes or tribal organizations. In conclusion, let's go over some of the facts that we learned during the presentation. We discussed that all women may be affected by cervical cancer, but Hispanic women and women between the ages of 20 to 50 are more likely to be diagnosed. HPV is the main determinant in cervical cancer. Pap testing and the HPV vaccine have made a tremendous impact on cervical cancer. All women need to be screened every 3 to 5 years for cervical precancer. And the GBCCP is a great community resource that offers help to underserved women in the fight against breast and cervical cancers. Thank you so much for listening to my presentation, and I hope that you learned some great information that you will be able to take into the field of social work. Next, I will list the resources that I used to make this presentation.